You're watching CTOM TV. Knowledge is power.
So you were diagnosed with CLL
Yes, stage
and
0.
prostate cancer.
Yeah.
Oh boy. Okay. And so your Gleason was 4+4. Okay. And so you started on Zoladex, ADT. Great. And you had a PSMA scan in Vancouver. Yay.
Yes, yeah, as part of a clinical trial.
Yes, that's how it was given. Yeah. So you started on Xgeva. I'm not really good with the brand names. So Xgeva.
Xgeva is the one to make sure you keep your bone density.
Yes.
Yeah, I forget what the drug is called itself.
Xgeva. Yes. Okay. So Xgeva. Okay. Denosumab. That's right. I remember it now. Okay, great. Good on your oncologist for prescribing a bone modifying agent. There's also zoledronic acid, but Xgeva is a good one too. It's a rank inhibitor. What else do I see here? Zytiga. Zytiga is
that's the abiraterone.
Abiraterone.
Yes. Yeah.
Okay.
I've been on that for about 9 months now.
Okay. Okay. How do you feel on that?
I mean, I've got fatigue and muscle loss over the last 3 years. It didn't just start with the abiraterone; it started with the Zoladex.
Okay.
So, yeah, but still functioning.
Yeah. So that's a steroidal inhibitor, androgen receptor antagonist. So you've had, so your PAC, it looks like you're responding really well. Had genetic testing. So you have a BRCA2 and a HOXB13 mutation.
Yes. Yeah.
So have PARP inhibitors been mentioned to you at all? Yes.
Well, I will on a clinical trial called the Magnitude one, which is the abiraterone, prednisone, and possibly niraparib, which is one of the
niraparib. Yeah. Wow. Well, that's great. I think you're doing amazing. I mean,
well, unfortunately, my PSA has been increasing. It initially dropped from 11 down to 3 last October when I started on the abiraterone, but now over the last few months it's increased continually, and it's up to 21. And the most recent bone scan showed 5 new tumors on my spine and ribs and things.
Okay. So I would suggest tumor DNA sequencing, definitely. And expression testing. I mean, if that's your goal, or, just go straight for the theranostics. Definitely. If you can go to Germany for theranostics. Now you're saying that you're not eligible due to the CLL, correct?
What is there's a clinical trial in Vancouver with the lutetium-177.
Yeah.
But I'm not eligible because of the CLL.
Yeah. So, you've been really on top of the technology here. That's great.
Well, I've done a lot of research.
Yeah,
I'm up at 3 a.m. doing this too.
Well, yeah, you could be teaching this seminar. That's wonderful.
Well, no, not quite that level.
So, I would like to see you try darolutamide. With ADT, obviously.
Yeah.
And,
what about
docetaxel?
Pardon?
And docetaxel. Yeah. So it's the triplet. So the clinical trial for darolutamide that worked really well included ADT and docetaxel.
So both chemo, the
AR antagonist and ADT. Yes.
Yeah. And
triple threat.
Where would I get that done?
Well, I would be pushing your oncologist. I know I spoke with an oncologist recently who said he's been able to get darolutamide, and they're pushing it. The drug company's pushing it, and he's been able to get it for a bunch of patients. I would definitely upscale it from abiraterone. Now, one thing to consider too, because this is a bit of a bone of contention for me, is castration resistance is not something that occurs overnight. It's something that happens slowly, and obviously it's damage to the androgen receptors themselves, and it just happens it'll happen in certain cells, but not all of them. So a lot of doctors will say, oh, you're castration resistant, cutoff value right now, we're taking you off the AR antagonist. And that's a big mistake, because then you're not dealing with all of the tumors that are still castration sensitive, or in the case of darolutamide, it works in castration resistance tumors and mutated tumors. So there's a lot of variation going on in those androgen receptors that can be addressed and targeted by doing something like darolutamide, chemo, and ADT. You're basically hitting everything.
Yeah, they're definitely still keeping me on the ADT, on the Zoladex.
Yeah. Okay, well, that's good. Your doctor's doing a good job there. Now as far as CLL, what's the status of it?
Well, I'm stage 0, so no real.
I'm sure it wouldn't be a big issue. I would go to Germany for theranostics. I would try the darolutamide triplet combo, and then I would go to Germany for theranostics, starting with the lutetium and then move to the actinium.
Okay, I've got my next appointment with the oncologist in about 2 weeks.
Okay.
And they're trying to decide on the next treatment. And really what I'm kind of hearing is likelihood of radium-223 or chemo, which would be the
docetaxel.
Yeah.
Yeah.
What do you think of that?
I would go with the ADT, darolutamide, and docetaxel.
Okay. How am I going to convince my oncologist to be able to do this?
Well, the data is really good. From the
Interrupt
trial.
there. The right answer, Alex, is Alex will help you.
We can try to help you. Yes,
that is exactly why we're here.
Yeah.
So if you've got your meeting in 2 weeks, we can most certainly get your medical records, and Alex and his team can have a review and draft a report for your oncologist and give it to them before your next meeting.
Mm-hmm.
So by all means, if you want to tackle it yourself, you've obviously come a long way.
Yes, definitely.
But certainly, if you just, if this isn't your wheelhouse necessarily, although you've been dealing with it for quite some time. So certainly Alex and his team within 2 weeks can prepare a nice argument for
what I would suggest doing is maybe just getting you a different oncologist. I mean, your oncologist sounds really good, but if your oncologist is not open to this or doesn't want to do the paperwork for darolutamide or doesn't, really feel it's going to benefit you, you can consider getting a different oncologist, like a community oncologist. I know some good community oncologists that, they'll do what you ask them to do. The problem is you may have to pay for darolutamide out of pocket. I think I'm seeing more and more patients get it though.
Mm-hmm. No, I'm not. I shouldn't say that he's going to be resistant. I don't know at this point.
Yeah,
okay? Right. They've been very open to me getting, genetic testing, doing the PSMA, things that I've suggested.
Yeah, that's great.
So I'm not saying they're going to be opposed to it at this point.
No, Dave, our rule of thumb is let's change as little as we possibly can for you. So we always want to start by assuming exactly what you're saying, that your oncologist is going to be open to the most current medical science information. And let's just get that in front of them and see what concerns or questions they have, see what we can do about that. And then if that's still a no and you'd like to go for it, then there are other oncologists in your area we can connect you with.
Mm-hmm. Yeah, I'm over in Victoria, just
okay,
for your information.
Sure. Andy, did you have any other questions at this time?
Oh, yeah, actually I did from earlier, the one on when he was mentioning about the liquid biopsy.
Yes.
Is that measuring the circulating tumor cells?
No, it's measuring the circulating tumor DNA. The circulating tumor cells technology is just not there yet. The problem is in order to determine, so what's important about detecting a tumor cell is detecting a stem cell, because they're the only ones that can metastasize. So we're not able to do that. What they do right now is they use a bunch of different cell surface markers that are typically overexpressed in cancers, but the problem is they're also expressed in normal cancers or normal cells. So they're not a guarantee it's cancer. With the tumor DNA liquid biopsy, we're basically looking at mutations that we know only occur in your cancer, and because we've done the genetic testing for your cancer. So we know that this KRAS mutation is only in your cancer cells. So we're able to use it as a surrogate for liquid biopsy testing.
Another thing, Dave, you sometimes, because of Alex's expertise, he gets very specific about things. There's a difference between the type of tests that he's designed and uses than circulating tumor DNA, which might have been what you were asking about.
No, I think he was asking circulating tumor cells.
Cells, yeah.
Oh.
Because that, as part of the clinical trial that I'm on, the magnitude one, they measure that, but they couldn't do that with mine because of my CLL. That's why I was wondering about that liquid biopsy.
Yeah, interesting.
Yeah. Another question. So I was on this trial and potentially had the PARP inhibitor.
Yeah.
But I'm pretty sure I ended up with the what's the word I'm looking for?
Oh no, the placebo.
The placebo, yeah.
Oh.
And my doctor suspects I also am. Now I'm going to be going off that clinical trial because when you have 2 or more new tumors, you're no longer eligible for the trial. So I've asked.
They don't do a crossover?
No, not that I know of. Not on this one. They don't. But I have asked that I want to find out if I was on the placebo or not. So the question I have for you is there another way to maybe measure if a PARP inhibitor would be useful, like olaparib or something?
Well, do they give you a pill?
Yeah, oh yeah. I have the pills.
Okay, so you can send that to Victoria. There's a mass spec lab, and they can tell you exactly what it is.
Oh, I like that.
Yeah, it's about $1,000 or so. We do this a lot. I'm totally against closed label trials. I think it's ridiculous in this day and age. They're still doing that. There's really no purpose for it. If you do proper genetic stratification, I just can't believe that the doctors are actually suggesting this for people. You need, someone with cancer needs to know they're going on the drug they're taking, and there's no reason to keep it covered.
Back to that liquid biopsy, the liquid biopsy monitoring is a tool you can also use.
Yes.
To determine whether what you're taking is actually working. And that would be another way, but first and foremost, of making sure your treatment is working well, but also another way to assess whether you're on a placebo or not, to a certain extent, because it's just measuring that ratio of those live cancer cells in your blood. And if it's not changing and you're on this drug and other folks are getting a benefit, then there's a probability.
Yeah. The problem with your cancer is it's a bit of a black box. We don't have any genetic information or any expression information. Just that you have a BRCA and HOX B13. Do you know which BRCA2 mutation you have? Do you know what kind it is? Is it a?
Yeah, I think it was the BRCA 1. Let me just see. 2, BRCA2.
Yeah, what mutation is it? I mean, there's many types of mutations that have different impact. So it can be a truncating mutation that basically stops production of the gene itself.
I'm not sure of that.
It should say on your pathology.
Yeah, I'll have a look at the genetic report that I got.
Okay. Great.
So then, kind of back to that question. I'm assuming the triple combination one potentially has a reasonable amount of side effects, whereas the PARP inhibitor, if assuming it's useful, would have less side effects and maybe even be more targeted to my mutation.
Well, you have to understand at this point in time, you've probably got a lot of heterogeneity. And we don't know what mutations you have that would prevent that PARP inhibitor from working. So, without having full genetic information, it's really hard to go with a single agent targeted therapy. I wouldn't want to spend time on that right now. I would really tend to focus on doing something that's going to be more inclusive.
Okay, thanks.
Okay.
Thank you,
You're
Dave.
welcome.
Thank you for watching Cetome TV. Subscribe below and stay informed.